Good morning or good afternoon. I'm Monica Pica with Sachs Healthcare, and I will be your technical producer for today's webinar. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and you may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. Please make sure you're not behind a firewall, as this will prevent you from viewing the presentation. Our moderators, as well as the speaker today, is Jose Chavez. Dr. Chavez is currently a critical care clinical nurse specialist, cardiac intensive care unit, and cardiac PCU at Cedars-Sinai Medical Center in Los Angeles, California. Jose is very active in several professional organizations, as is currently the chair of National Association of Clinical Nurse Specialists and the Critical Care Clinical Practice Council. He is a reviewer for several peer-reviewed journals, including the AJN. A sought-after speaker at regional and national meetings, Jose has also published papers and abstracts in several peer-reviewed journals. Welcome.
Good morning or good afternoon. Thank you, Monica, for that very kind introduction. The title of today's webinar is Assessing Lung Function and Cardiac Output with Capnography. Speaking today on this very timely topic is an expert and colleague, Dr. Tom Ahrens. He is one of the founders of Vivian Health. Tom has more than 25 years of experience as a critical care nurse and is the author of five books, more than 100 papers, and more than 40 scientific publications. His book, Essentials of Oxygenation, received the Book of the Year award from the American Journal of Nursing. He is a recognized authority in sepsis and has given numerous lectures around the country on the subject. Tom is a fellow of the AN, which named him one of its first edge runners in 2006. The award recognizes innovations resulting in better care for patients, families, and the community. Our speaker disclosed no relevant financial relationships associated with this presentation. This educational activity is approved for 1 contact hour for nurses and RTs. A link to obtain credit will be available at the end of the webinar. Support for this educational activity is provided by Philips. And at this time, I'd like to turn the presentation over to my friend and colleague, Dr. Tom Ahrens. Tom?
Jose, thanks so much. Again, it's always fun working with you. And welcome, everybody. The topic we're going to go over today is looking at lung function and cardiac output with capnography. We have a few simple learning objectives, and we'll cover these in fairly good detail. But one of the things, just even before we get started, is capnography is a fascinating technology, and it's quite surprising we still haven't seen it be used to its maximum potential. If I was to have one technology to monitor on a patient, it would be capnography. And we'll go through that. So these objectives kind of address that. So how can we use capnography to identify somebody who's at risk of oversedation? Actually, it works as well when you're looking at perfusion. And capnography is the only vital sign that measures both ventilation and perfusion. So we'll talk about that objective. And we'll look at both, if you look at arterial carbon dioxide levels and end-tidal carbon dioxide levels, what that does in terms of monitoring. And then we'll also look at a little bit of pulse oximetry. And we'll show some examples of how this applies to COVID. But remember, COVID is really a pulmonary dysfunction. And there's nothing different between that and other types of pulmonary dysfunctions. So from an assessment point of view, it's really quite similar. So I'm going to start by going over something, and I do want to emphasize all of those of you in attendance. If you know capnography already, this is going to make the talk easier. If you're unfamiliar with it, I strongly encourage you to try and use it, because it's not only is it easy to use, it gives such rapid feedback that you can identify patients at risk or someone who's changing literally within seconds. And that's why you've seen vital sign or capnography called 15-second triage tool. If I'm on a rapid response call, a capnogram will tell me more than almost anything else in terms of how much danger that patient's in. And you can make a case that if you have a normal capnogram, a normal end-tidal carbon dioxide level, which is just the PET CO2, that's between 30 and 40. You can make a case that the person's breathing adequately and his cardiac output's adequate. So, when Jose and I were looking to put this program together, we kind of have some questions embedded in here, and I'll just go through these. If you don't know what capnography is and what's normal, well, let's go through that real briefly. So remember, capnography is just the measurement of exhaled carbon dioxide, and we can see that in a numerical display, and we can also see a waveform. The value that we're primarily interested in on this slide is number 4, where it's got the red arrow pointing to the end of a capnogram waveform. And this is at the very end of exhalation. Notice right after the number 4, you see the number 1, where a steep decline occurred, and that's inspiration. So, but at 4, it's what we call end-tidal carbon dioxide levels, and this is the very end of exhalation. This is the number that's probably going to be close to arterial carbon dioxide levels in a normal person. And if this level starts to change, it can either reflect a change in breathing or ventilation or a change in perfusion or cardiac output. And so I'll show you this. So I mentioned this before, but is an end-tidal carbon dioxide level, again, just the PET CO2, and the P just stands for pressure, ET stands for end-tidal, CO2 stands for carbon dioxide. So if an end-tidal CO2 of 30 is present on a patient, that means the patient's safe. And you can make a case that's true. And I'll give an example. And I'm going to show you this slide briefly now because we'll talk about it a little bit later. Remember that normally is a person has ventilation and perfusion. So we ventilate the alveoli and we have blood flow perfusing the alveoli. So carbon dioxide diffuses, as you know, very quickly, much quicker than oxygen. And so it's in the blood, immediately will go into the alveolus. And so that concept is very important when we start to look at abnormal levels of end-tidal CO2 levels. So I'm going to come back to this slide in just a little bit. But keep in mind that a normal end-tidal CO2 level is very close to an arterial carbon dioxide level, just a little bit below. So any one of us right now, if you'd measure our end-tidal CO2 level, probably going to be between 30 and 40. And that's because our normal arterial level is about 35 to 45. Now, that's assuming ventilation and perfusion is normal. As long as we have normal blood flow to the lungs, normal ventilation, the end-tidal is going to be about 30 to 40. That's pretty simple. So let me show you how easy this is to use in clinical practice. It's far easier to use and to measure than many other things that we use. For example, why would an end-tidal level go up? Well, if you ever see an end-tidal level climbing, that's generally bad. Usually means the person isn't moving air into his lungs very effectively. That means ventilation is being threatened. And he might even need to have his airway protected, including intubation or BiPAP. Now, what happens if the end-tidal falls? Well, that's also usually bad. It could be because the person just started breathing faster and they were anxious. That's the best case scenario. Worst case scenario is that, particularly if they're on a ventilator, the airway's lost. Tracheal tubes become malpositioned. The other thing is it could be because they lost cardiac output. And again, I'm going to show you some examples from my clinical practice that shows this very clearly. So, but I want you to keep in mind that this is very easy to use. So if I have an end-tidal monitor on a patient, and I see a rise of over 5 millimeters. That's abnormal. And if you have a portable capnography unit, you should try this. Try and see how long you can hold your breath. Watch how your untitled doesn't change all that much. Our cerebrospinal fluid that bathes the ventrolateral surface of our medulla is what controls our breathing. And if we get a small change in carbon dioxide, it's a powerful drive for us to breathe. And so we don't see end tidal levels go up very much, just like we don't see arterial levels for carbon dioxide go up very much. If they go up at all, it's usually a bad sign. So if you have a rise that's even higher though than 5, say 10, you have a person who's getting analgesia, for example, you might need to consider reversing it, simply because at this point, you know your pH is starting to drop. So that's pretty simple. Now, keep in mind that if you have an end tidal level that's increasing, you certainly can get a blood gas to verify it. That's not necessarily, you don't have to do that. But keep in mind that the end tidal doesn't necessarily always predict perfectly the arterial level. That's a function of dead space. And again, I'll give you an example. We had a patient come in with a severe asthmatic episode, and we put his capnogram on. It was reading 66. He did get an arterial blood gas, and the arterial carbon dioxide was 99. So there is a big difference. Normally, that's only a 5 to 10 millimeter difference. So that huge difference between the end tidal and arterial was because the patient also had an increase in dead space. And again, I'll talk just a little bit about that. But from a clinical point of view, just remember, if you see an end tidal going up, that usually means ventilation is being threatened. Now, this is such an easy concept to use. Why are we not using it all the time? And the answer is, I don't know. It's so easy to use. We can use it with a portable device. On the left-hand side of the screen, you see a device that's used called a microstream measurement. And multiple companies make these. And this is a device I carried with me on practice in case I had to go evaluate a patient quickly. On the right-hand side, you see a mainstream monitor that shows a capnogram. And I want to show you how easy this is to use. Here I am wearing one. This is so easy in terms of its application and use that you can use this on anybody, anywhere. You can use it pre-hospital. You could use it in clinical offices. You certainly can use it on rapid response calls or on a floor. And in our ICUs, we should be using it virtually on every patient. So especially our ventilator patients. So this is an example. You can see this red arrow pointing to where the capnography sampling port is on the ventilator circuit. So what we do in this case here is we sample just a tiny amount of air. There's very little air is used to make the measurement. And then it's taken to either the monitor or it could be used to the portable device. So I want to be clear, this is something that we can be using anywhere. And one of the things that we want to make sure that we understand also is that the waveform can also give us information. And I'm going to show you some examples. So this is a normal waveform. I showed this a little bit earlier. So when you take a breath very in, take that breath very in, you've inhaled almost no carbon dioxide. You all know that the composition of room air is 78.8% nitrogen and 20.9% oxygen, with only a tiny bit left for other gases. And carbon dioxide has very little in terms of our inhaled air. So that number drops to 0. These numbers are off a little bit, or these arrows are. But generally, when we take a breath very in, the end tidal would go to 0. And then on exhalation, you would see the level climb. You get a normal alveolar plateau level. And that's that flat line where number 3 starts. And then it ends at number 4. What this is really the alveolar plateau, and that should be nice and flat. And it should be reflecting alveolar carbon dioxide levels. Now, these can change. So for example, the patient I mentioned who had asthma, what he has is a very short exhalation phase. And notice that he does not have that flat alveolar plateau phase. And so what occurs then, what he's breathing is he's taking a very long inspiration quick expiration. And we've seen this be used as an indicator of the effectiveness of bronchodilator therapy. So if you see a bronchodilator therapy working, you're going to see what you notice on the bottom of this slide is the alveolar plateau returns. So having a waveform available makes your interpretation more robust. You can actually look at more than just the number. Now, I do want to mention briefly about oximetry. And capnography and oximetry, and I know you know this, but they're different in what they measure. They're very, very complementary, but they are clearly different. If I had to pick one, I would pick a capnogram over an oximeter. Not that you should have to, but it just shows what the value of the devices will do. So a pulse ox is very good. We've had this around for decades, and it's very good at telling us about a worsening of ventilation and perfusion, specifically what we call an intrapulmonary shunt. And the number or the letter Q here just stands for perfusion. The S stands for shunting. The T stands for total blood flow. And so what we have here is any condition that's going to obstruct air coming in without obstructing perfusion. So that's COVID could do that, atelectasis, pneumonia, any heart failure that could do it. So what we're looking at is when you have a patient whose pulse oximeter starts to drop, it tells you is there something in the lungs. It does not tell you if the tissues are getting oxygen. It only tells you there's a change in lung function. And specifically in obstructing ventilation, so we're not getting enough air so we can add oxygen to the blood. Pulse oximetry does not tell us hardly anything, though, about the effectiveness of breathing. And I'll give some examples of this. These are from my clinical cases. We had a young woman who had recently underwent breast cancer surgery, and she had been in our intensive care unit on her second day post-op. And you've probably had similar experience with this. When I went to see her, it was like 6:30 in the morning, still dark out. And I went and I stood next to her bed, and I noticed I was standing in something sticky. That's never a good sign. So I stepped back, I turned on the light, and I'm standing in a pool of her blood. And what had happened is her arterial line had become disconnected. And now her heart rate was up, her blood pressure was dropping, pulse oxygen read 98%. And when the house officer came in, he said, well, at least her oxygenation's okay. Well, that's not exactly true. If you look at how oxygen gets to the tissues, and you know this, it's based on how much hemoglobin you have and what your cardiac output is. So this person had tremendous threat to tissue oxygenation, but her lungs were still working, and so the pulse oximeter was good. So the point of this being is that this person was in danger. Now, we had a bunch of other things we had to check, like why the monitor didn't go off and why the line came disconnected in the first place. Point being is that this person's pulse oximeter didn't tell us anything about the risk this patient had. And that's not a criticism of the oximeter. It's basically saying the oximeter can only measure how well the lungs are oxygenating the blood. Now, this is a topic I've become fairly passionate about, and I think that all homes should have oximetry. Probably aware that in COVID, we started noticing that patients would have occult hypoxemia. So they would feel pretty good, but their oximeter, when we put it on, was reading low. We really want to avoid things like that and get oximeters in homes. I've been around long enough, oximeters used to be pretty expensive, but they're not anymore. And if a patient has any risk of lung function, and this could be from a pneumonia, COVID obviously, if they have asthma, if they have heart failure, these are all patients who could benefit from having an oximeter in their home. And again, you know this, an oximeter takes seconds to get an accurate reading. And if we were able to make sure every home in the country had an oximeter, we could get some early warning signs of danger. Now, what's it cost? Oximeters now have become extremely inexpensive. There's a company that I work with, and I don't get any financial reimbursement from, but All Heart. They have oximeters available for about $5. If you are interested in getting some for yourself, or your family, or your patients, I would go to their website. They're high quality. I've used them for several years. I have different types of oximeters that I use at my outside the clinical setting, including hundreds of dollars worth oximeter. Very, very good. And these devices work just as well. Now, they don't have Bluetooth capability, which is one of the reasons they're. But it's important to keep in mind that an oximeter is going to warn us if a person has worsening obstruction in terms of his ventilation, or they start to lose, heart failure starts to get worse, flood the lungs, alveoli become filled with fluid, that will make the oximeter drop. It doesn't tell you about how they're breathing. And so I'll give you, again, some examples of this. So now I don't want to get into great detail because sometimes this gets confusing, but I'm sure you all remember the oxyhemoglobin dissociation curve. And I'll give you a real quick refresher. So remember that a normal oxyhemoglobin level is determined by the arterial PO2 level. So what happens is, and I'll use this as an example of happens with carbon dioxide. If a patient starts to hypoventilate, that'll make their carbon dioxide level in the alveoli go up. Now, gas, as carbon dioxide goes up, it has to displace another gas. And the gas it will displace is oxygen. So let's say, for example, an arterial carbon dioxide level and subsequently an end tidal. An arterial level goes up by 10. That will push the PO2 level in the alveoli down. Okay. Now, clinically, I want to know if an arterial or end tidal carbon dioxide level is climbing by 10. That's significant. But based on the oxyhemoglobin dissociation curve, if an arterial level goes from 90, increases by 10 to 80, that will make very little difference in the oxyhemoglobin number. So the pulse oximeter would change maybe from 98 to 97. That would be unrecognizable in a clinical setting. So if I'm watching an oximeter, not a capnogram, I would not know if an arterial carbon dioxide level had increased by 10. Then this gets worse if we put a person on oxygen. Because if you add oxygen, then you've increased the arterial PO2 level to a point that the oxyhemoglobin curve won't even be able to measure it. So for example, many of you may be like me, get routine colonoscopies. When they went in for my last one, I knew the nurse anesthetist and she was getting ready to put oxygen on me. And I said, you know, you don't need that. She had actually been to one of my classes. She laughed and she said, I know that. And I said, where's the capnogram? Getting it. And she shouldn't have to do that for me. She should do that for everybody. You don't need oxygen during a procedure like a colonoscopy. You need a capnogram. You don't need to give the person oxygen. They're not going to have trouble with breathing. What they're going to potentially have is the danger from oversedation. So that's what you need a capnogram for. And here's just a clinical example. So let's say that you have a person who has a drop in their PO2 level, 95 to 85. It's not a major change. And if you look at the pulse oximeter, it would decrease by about 2%, again, based on the oxyhemoglobin dissociation curve. So that's not a big deal. Wouldn't worry about it. But look at his end tidal CO2. It went from 39 to 54. This is what's clinically significant, and that's what made the PO2 fall, was the rise in the carbon dioxide level. If you were measuring a pH at the same time, notice the person now has become acidotic. So this is a bad sign. Pulse oximeter didn't detect it. And then, like I just mentioned, if you put them on oxygen, you raise even a small amount, like 30%, the PO2 level goes up, pulse oximeter goes up, and now you don't know what's happening at all. Look at the Untitled. It went up even higher. Now the pH is even lower. This person's in danger. And so an oximeter is only going to tell you how well the person is oxygenating his blood. It won't tell you about his ability to clear carbon dioxide. And that's why you really need both of these. And so I'll give you again a couple case examples. Talk about colonoscopies. Well, here's a case one. We had a gentleman come in for an outpatient procedure. He gets propofol. Capnography is being measured. Nasal cannula device, very simple. Notice that 10 minutes into the procedure, and the procedure may not last much longer than this. If you look at this, this person in any danger? Heart rate, respiratory rate, blood pressure, pulse oximeter. That's all you're measuring. He's fine. It is Untitled. This person's at risk. And unless you're using the right technology, you would not know that. So one thing that we've done a lot, certainly I have in my careers, with weaning from mechanical ventilation. So take a look here. This is a patient who's being weaned from the ventilator. She's got a mainstream carbon dioxide level in her ventilator circuit. So 15 minutes into the weaning attempt, I want you to take a look at this. Tell me, is this person in any danger? Heart rate has gone up a little bit. Respirate maybe a little. Blood pressure hasn't changed much. Oximeter hasn't changed much. Title's gone up by 16. This person needs to be put back on the ventilator because they're clearly not able to breathe properly. And it just shows how easy it is to identify a patient at risk. This next case was where I was asked to be a legal consultant on a case that involved a patient who had a cardiac arrest and had suffered irreversible brain damage. And so the hospital was being sued along with the nurses. And so I was a witness for the defense and the nursing staff. And so in this case here, we had a 44-year-old man who came into the medical intensive care unit. At the time, he had an unknown cause of a fever. It turned out later he had miliary tuberculosis, but he was very short of breath. He was hypoxemic. Notice that his blood gas, he was slightly acidotic. His arterial level was 38. His PO2 was 44, very low. Pulse ox very low. So they intubated him. Now he was very short of breath, very uncomfortable. They put him on the ventilator. They used an older technique, intermittent mandatory ventilation. Had him on a respirator at 12, but he was breathing 44 times a minute. Now, he is so restless. He had extubated himself. Actually did it twice. So they finally ended up giving him significant sedation, and they actually also gave him a paralytic. So if you take a look at this case here, and so I'm looking at this case and say, are these nurses at risk here? Did they do something wrong? Well, they had a capnogram, which was wonderful, and it actually saved him. Because what had happened, notice that the capnogram had risen to 47 from 34, where the other vital signs were less clear as to what would be happening. The nurse had called the attending physician and let them know that the Untitled had climbed. Absolutely the right thing to do. The attending physician said, well, don't worry about it. Well, he said that because he didn't understand capnography. And so this was an example where we were able to defend the nurse successfully. She was monitoring the patient properly. She did try and reach out to the physician. And this patient here subsequently had a cardiac arrest. He's already on the ventilator, but he had a cardiac arrest and did suffer significant brain damage. This was preventable. They had just given him, well, they shouldn't have given him the paralytic. Probably the sedation might have been. So this isn't, what I'm asking you to look at isn't anything new. This is a standard of care. This is basics standard anesthetic monitoring. If you're given agents like propofol, certainly paralytics, then you're basically doing anesthesia. Now, it's interesting. I just want to go over a very, very simple application. And I've been advocating for this for a long time. And I've been in practice for over 25 years. One of the things that I had done is advocate that every patient on a ventilator needs to have capnography in place. And look at your hospitals. If you're not doing this, you absolutely have to start this immediately, because the capnogram is your line of defense from something going wrong, like an airway disconnect. And when we had looked to start doing this practice at our hospital, I had asked, our administrator that we need to be budgeting for capnography for all ventilators. And I have a great relationship with them, and they said, so how much is it going to cost? Well, we're a big hospital. So I said, it's probably going to cost $500,000. So they said, okay, we'll see what we can do. And, I got a call the day before the authorization committee was to meet, and they asked me, can you explain a little more about this capnography? It's not catnography. So I said, if you can't say it, let me go to the meeting. But they didn't let clinicians go to the meetings. And so we were denied. We were denied for about 4 years. We got it eventually. And that's why. You know why. We had a young man extubate himself. He'd been severely injured in a car accident and was very tenuous in terms of his survival. He was found for a CT scan, being disconnected from the ventilator, cardiac respiratory arrest. We paid a lot for that lawsuit, more than. But the point being is that I want to show you a case where what this looks like. So the capnogram is what was critical. So notice the waveform on the bottom. That's a normal capnogram waveform. So in the case I'm going to show you is the ventilator disconnection alarm is immediate. It's within seconds. So you can tell right away if somebody's come off a ventilator, or if the tubes become disconnected, the ET tubes dislodged. It's very quick. So here's a case. We had a young woman who was intubated, and again, like the gentleman before, it was for a CT scan. She had extubated herself. Now the CRNA was present, so the CRNA immediately reintubated her. Here's where it got bad, and this was another lawsuit case. So the young woman was anxious. She extubates herself again, but now the CRNA isn't present. So what the nurse attempts to do is to reintubate her. She waits for the young woman to breathe in, and then she tries to slide the tube back in. Obviously, you should not do that. Tag the person until the CRNA gets back. But the nurse thought she heard breath sounds. She thought that the E-tube was in the right place. All she had to do was look at the capnogram. Here's a capnogram. Shows a flat line. You are not in the trachea. If you're in the esophagus, you'll get a flat line. And because there's no carbon dioxide in the stomach, unless you just drank a carbonated beverage. Unlikely in this case. So you don't listen for breath sounds. You watch the capnogram. And is it flat or is it showing a waveform? You could even use this, and there's recent research that supports this, that you can use this in terms of placing NG tubes. Place an NG tube, and not a small bowel feeding tube, but just an NG tube. You want to make sure you're in the right spot. All you have to do is attach it to a capnogram. The way you do this is very simple. Slide the NG tube in about 20 centimeters, then you pause, put a capnogram on, and see if you see a flat line or do you see a waveform. For example, if you take a look, let me show you the illustration. You see a waveform like this on an NG tube, you're in the lungs. It's that simple. And it's not a difficult thing to use or apply. Some centers you don't have the right adapter, so you have to rig it to get the right adapter. But the point being is that capnogram tells so many things, and this is why I like to spend time going over all of its applications. An even bigger one that we would use. And I will show you some case examples in this as well. So this goes back to some work I did in terms of economics of critical care units. I was invited to do a presentation at the ANZAC conference in New Zealand. And this conference was being held in Rotorua, New Zealand. Mostly Australian, New Zealand people in attendance. And I was on a panel where they asked me, so what does it cost? How much money basically each country has for healthcare. And we were talking specifically about critical care. I was on a panel with 13 other people, and when they got to me, I said in the U.S. we spend about $80 billion a year in critical care alone. It was more than the budgets of all other participants on the panel. The reason I'm interested in this is because we spend a lot of money, again, as you know, on people in their last year of their life. And is there ways that we can avoid some of that? Well, specifically, we were interested in what happens in people who have cardiac arrest. How often do they survive? And is there a way we can identify people at risk of death by looking at a capnogram? And the answer is absolutely you can. So remember that normally at the end-tidal carbon dioxide level is only a few millimeters, 1 to 5 millimeters below an arterial carbon dioxide level. There's only one reason for that gradient to widen, and that's in dead space. So you might remember I mentioned this slide to you before. So this slide on the bottom shows a pulmonary embolism. So now there will be no blood flow into that area. There's blood flow into other areas, but not that area. And so what this means is the carbon dioxide level is going to be shifted to the other areas that do have blood flow. Now the carbon dioxide level that went into the area with no blood flow is going to be closer to what's in the air, which is mentioned very, very low. So what happens is the bigger the obstruction of blood flow, the more room air is basically going to enter the lungs, and so the exhaled carbon dioxide level starts to fall. And I'll give you a case example. We just extubated a patient in our medical intensive care unit, and we had capnography on him. He was breathing spontaneously, and he suddenly got short of breath. His end tidal went from 40 to 10 in a second. So immediately, there's only one reason why that would happen. That's that he threw a pulmonary embolism. And the medical director was right outside, so I got him. We decided to go ahead and let's give a thrombolytic. In 12 minutes, the end tidal went back to normal and all his symptoms went away. Didn't have to get any type of pulmonary angiography or VQ scanning. Capnogram told us that he had a pulmonary embolism. It was that quick. So what I want to do is you look at reasons why dead space would go up in a patient, and that means why does the arterial end tidal gradient widen, or even more simply, why is an end tidal level lower than normal? PEs can cause it. Mechanical ventilation can actually cause it. Hypovolemia can cause it. Let me show you why that is important. Typically, if you get an increase in dead space, physical signs won't tell us anything. A person can become tachypnic, breathing fast. But unless you're measuring the tidal volume, you don't know if the minute ventilation's gone up. So again, if any of you are in attendance and you start to breathe fast right now, you're probably going to take normal tidal volumes. And I'll guarantee your arterial carbon dioxide, if you're measuring a capnogram, they would both drop. That's normal. That's because you have normal lungs. We have a patient who's breathing fast. We don't know if the total ventilation, what's called the minute ventilation, or V, actually has changed because we can't measure tidal volume. So keep in mind that physically it's hard to tell if a person has a change in dead space. And this is where we got into looking at blood flow. We had a very low carbon dioxide level, and something's probably wrong if they're not just over breathing, like anxiety. What would happen is if they have a very low carbon dioxide level, there's a good chance they've lost blood. Not from a PE, just blood flow in general. And so let's take a look at how we can identify this. And again, I'm going to give you another case example. So the idea that capnography could predict blood flow during cardiac arrest has been around for a while. Belenda first identified it in a paper he wrote in 1978. We started to see several articles about this in the 80s. And then Levine, Wayne, and Miller published a paper in New England Journal of Medicine in 1997. Said if you had an end tidal level less than 10, cardiac arrest after 20 minutes, everybody died. So 100% mortality rate if you had a low exhaled carbon dioxide level. So this is a critically important thing to have. And I mentioned that we should have oximeters in homes. It's a good chance you should have a capnogram as well. They're just not as inexpensive. Now, the AHA, the American Heart Association, certainly has recognized this as well. Now, they recognize it really from identifying ET tube placement and return to circulation. It can be more than that. And that's really what we want to look at. So I'll give an example real quick. This case happened to me outside the hospital. Going to a winery with some friends of mine. And we pull into the parking lot, and man runs up to the car, who we found out was the owner, and he asks us, are any of you doctors or nurses? How many of you had that happen to you before? What do you want to say? We were going there to go to the winery, some wine, but we also wanted to help. And so he said, what can we do? And we run over where this young man's laying on the ground. He looks like he's in his early 30s. He's not breathing. And I asked the owner, I said, do you have an AED? 911. He said, they'll be here in 20 minutes. They're way out in the country. I wish I would have had was a capnogram. And so, unfortunately, we tried to resuscitate this young man, but we were. Here's what the capnogram would have told us. You have an end tidal CO2 level that's greater than 10, and certainly goes up with resuscitation. That's a great sign. You have an end tidal less than 10, terrible sign. And so the whole point of this would be is that when we're trying to monitor patients, got probably no better case than this one here. Second. Okay, so this example, Mr. Snitzer, you can find this in the literature, the published case. Fascinating case. So he has a cardiac arrest, okay, ventricular fibrillation. He has first responders doing CPR for an hour and a half. That almost never happens. Had 12 defibrillations. After 10 days in the hospital, he went home. This is awesome. I'll show you why. Take a look at his capnogram during this whole time. Capnogram was reading 28 to 36. And once he got to the hospital, they were able to do a successful angiography and removal of the clot. But the end tidal CO2 was saying, keep going. This was good. He had good perfusion. So the CPR was being effective. These first responders deserve all the credit in the world. They did an awesome job. Now, what happens if the end tidal is lower? So let me give you some examples. So this is from a study we were doing. We had a 66-year-old woman comes into the emergency department and found down by her husband. And a first responder's been doing CPR for over 20 minutes. Capnogram value is reading 6. Okay. This is after 20 minutes. I want you to think, what would you do? Wife's in the room, or the husband in this case here was in the room. And what are you going to tell him? So what the entitle's saying is the patient's not going to survive. And this is what we told the husband. Capnogram is showing that there's such poor blood flow to the from the heart to the rest of the body, including the brain, that this not only will his wife die, but should she live, she wouldn't live long. So it does help. Here's another example. This is a patient we had recently following COVID. A patient had been on the floor. Pulse oximeter alarm is in place and it goes off. And he's in cardiac arrest. CPR is in progress. He's been defibrillated multiple times. There's no return to circulation. Been doing this for over 20 minutes. Again, life is present. Take a look at the end tidal and what would you think we should do? The end tidal is reading 5. Again, these are signs basically of death. There's such poor blood flow that the capnogram can hardly detect it. We had a case where I had my office in the surgical intensive care unit. One of our nurses yelled for help. Knew something was wrong, so I ran into the room, and the person suffered a cardiac arrest. So I took the person off the ventilator and started to bag him. Now we have a capnogram in place. But this was during a research study I was doing to try and see if capnography would help survival. So the anesthesiologist said, "Tom, what's the Untitled reading in the study?" And I tell you, you're going to change your decision based on what this number is. He said, "Well, how long have we been doing this?" I said, "Over 20 minutes. I was okay, we need to stop." Now, this is the first day post-op for an esophagectomy. The attending physician comes in, and the surgeon's knows what he said is first day post-ops don't die. So we took him off, up CPR, got the rib spreaders, cracked open his chest, did manual cardiac massage. After about 20 minutes, his blood pressure came back. His Untitled is never over 9. So what do you think happens to this gentleman? He survives the arrest, 2 months in the ICU, another month in extended care facility before he dies. Think of what the cost was to his. We knew 20 minutes into the code he was dead. Value. This is where capnography has a much greater place than we're currently seeing. But what the AHA says to do is use capnography for pulse checks. And it's great at that. If you look at this, we've noticed this a long time ago, that if you have a person with a capnogram in place, you're doing CPR, there's no reason to check a pulse. You watch the capnogram, because as soon as blood flow returns, as soon as the heart starts beating again, you're going to see a rapid increase in what the capnogram value is. The waveform is reflected as well. So this would be an example. We had an Untitled of 15, but as soon as the heart started beating again, you'll see a rapid jump. I've seen this so many times, it is so striking that basically eliminate the need to do pulse checks. So it has a few very clear applications, and we only got a few more slides before we stop today. I'll try to give you a couple case studies to kind of point this out. So this is a gentleman who comes in with esophageal variceal bleeding. The varices have been ligated via endoscopy, and so there's no active bleeding. How's this patient doing? So we do a leg raise on the patient. Notice his Untitled goes from 27 to 38. That's a big jump. That tells us the person, remember when you do a leg raise, you're basically doing an auto transfusion. So when we did the leg raise, what happened is this increase in the Untitled CO2 level showed that he was hypovolemic and he needed fluids. So even though the bleeding might have been stopped, he still needed more fluids. And this has been another application of capnography, is how do we use capnography for fluid monitoring? Now, not just that, but heart monitoring. So here's a 71-year-old patient who had history of heart failure. She's admitted to an extended care facility. She'll be going home soon. Doesn't have any symptoms of discomfort. But one thing that we encourage is monitor the capnogram. So from the day before till today, notice that the capnogram went from 30 to 25. It's a bad sign. Remember, your capnogram doesn't change. It doesn't go up. It doesn't go down unless something's happening. And so a change of 5 millimeters basically told us, let's remeasure her cardiac function. Her ejection fraction changed, so she needed to get an echo. She needed to come back from the hospital for that. But her heart failure was worsening. She didn't need to go back into the hospital, but she needed to have her medications adjusted. So that's really where the capnogram value. Now, this was an unfortunate case. It involved a septic patient. So we had a 40-year-old gentleman. He actually owned his own landscaping company. He had stepped on, wasn't certain what, but it went through his boot and penetrated his foot. And he'd taken care of it at home. But his wife had noticed he had change in behavior. Brought him in the emergency room. So he had a clear cellulitis, and this person was actually sick at the time. So we had him do a leg raise. Notice the end-tidal went from 29 to 37. So even without hemodynamic monitoring, and I encourage you to use hemodynamic monitoring as much as you can. So like a bioreactance device could have been used. So, or a Doppler. But the capnogram is easy. And since the end-tidal went up from 29 to 37, it showed that he had hypovolemia. So the idea being is that we can do a lot with capnography. When you look at the biggest value of capnography is its simplicity. You can use on anybody, anywhere. It tells you about both ventilation. If a person's over sedated, ventilation will go up. The idea would be is that you have a person's capnography levels going up, the sedation might be too much. That's simple. The person has analgesia being given, same principle. The end-tidal goes down suddenly, it almost always means they've lost blood flow. Unless they're on a ventilator, they disconnected from the ventilator or the endotracheal tube. So the capnography has incredible value. Now, oximetry is, luckily, it's being used a lot more. It's very inexpensive. We can use it anywhere as well. It's a warning sign when something's going on in the lungs. COVID pneumonia, it could be any type of pneumonia. The respiratory distress syndrome developing could be something as simple as atelectasis, the asthma. We want to keep our pulse oximeter values over about 90, only because that after that, the oxyhemoglobin dissociation curve starts to drop quickly. But we could easily spend more time on this, but the principles of both oximetry and capnography are quite basic. And luckily, I think that you have them available. So that ends what we're doing today. And I want to turn it back to Jose for some Q&A and some closing remarks.
All right, thank you, Tom, for that great presentation on capnography. I'd like to remind the audience on how they can obtain their CEs for this activity. So, let me get this to the slide that we have our CEs on. And let me
I think you can see it, Jose.
Okay, so can you see it? I'm not seeing it, but I can hear. Do you see the slide, Tom? Okay, all right.
Yeah.
So this educational activity is approved for 1 contact hour for nurses and RTs. A link to obtain credit will be available at the end of the webinar. Support for this educational activity is provided by Philips. So, an archive on-demand version will be available on betteroutcomes.org. The on-demand version will be accredited for nurses and respiratory therapists. So at this time, we have a couple minutes to answer a couple questions here. We have some questions in the chat. Let's see. Let's go to the first question here. The question. Oh yeah, it's all right. I think we have time for a couple here. Let's see. The first question is, if a patient is tachypnic with low tidal volume and only moving dead space, and it lowers the end tidal CO2. So, what about the patient when they're tachypnic and low tidal volume, only moving dead space, and it lowers the end tidal CO2?
That wouldn't happen if you're only moving dead space. The end tidal would go up. So only if they're over ventilating will the end tidal go down. And so in that respect, if you're only moving dead space, it won't. The end tidal will go up.
Yes. All right. Our second question is this theory applicable when using the nasal cannula end tidal CO2?
Here's I think what the question might be, if you're giving oxygen, the end tidal, first of all, if you're not giving oxygen, the end tidal is perfectly accurate using the nasal cannula. We do it all the time. And we would encourage you not to be given oxygen if you didn't need to. One of the things that we do in our clinical practice is we overutilize oxygen. Patients generally can be fine with oximetry levels around 90. But if you have somebody on a face mask, that can limit the oxygen or the capnography value because you'll flush out the carbon dioxide levels. So to get around that, you almost have to use a nasal catheter to place into the person's nasopharyngeal area to get an accurate capnography level. And if your patient's awake, they won't like that. So it does make it harder.
Yeah. Let's see, the last question. So we have a registered respiratory therapist who assesses patients' breathing capacities at a university ALS clinic. Adding end-tidal CO2 to the assessment protocol will be very helpful, especially when it's difficult to perform PFTs in bulbar patients. Can you suggest an affordable method of doing this? I think the question is asking. So correct that O2 sats are very inadequate in assessing breathing in neuromuscular patients. So I think the question is asking if there's.
I was going to say, if you have a person on neuromuscular blockade, you absolutely need a capnogram on. And if the diaphragm starts to move, you'll see what they call the curare cleft. So you'll see the capnogram dip in the middle, showing that the diaphragm's starting to move again. So, using the capnography unit has a whole bunch of applications. And those of you in respiratory therapy probably have seen this many times, is the limitations of capnography is often due to our colleagues in medicine who don't request it to be used often enough. And it should be just standard monitoring in all acute and critical care units. Just like, if you have a monitor in place to monitor heart rate or oximetry, you should have a capnogram. So outpatient settings like PFT settings, all those are good examples of how it could be used.
All right, well, that concludes our Q&A session. I'll be turning the presentation over to Monica for concluding remarks.
Thanks, Jose.
Thank you, Tom.
Thank you. Thank you both so much. This does conclude our webinar for today. I'd like to remind the audience that there is a survey for you at the conclusion that will pop up immediately. We would greatly appreciate you sharing your opinions on today's webinar. We thank you once again, and on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips, we hope you enjoy the rest of your day.